Hello, everyone. My name is Stephanie Broxton, and welcome to the Smarter Together webinar series. This webinar series touches upon how multidisciplinary applied research can be used to make a community impact and improve the human condition. I'm delighted this week to introduce a panel for a discussion focusing on telemedicine during and after COVID, including experiences from those in the field. Today, we have a panel that is anchored by faculty here at Georgia Tech and Children's Healthcare of Atlanta. I will let each of them introduce themselves as they begin to talk about their work. Following their discussion, we will transition to a Q&A session with any remaining time. Please remember, we welcome your questions in the corresponding Q&A area throughout the presentation. Leanne, you can kick us off when you're ready.
Thanks, Stephanie. Thanks, everyone, for having us today. Excuse me. I'm Leanne West, and I am Chief Engineer of Pediatric Technology at Georgia Tech. And I'm also the President of the International Children's Advisory Network. And today we're going to talk to you about kind of how telehealth has evolved during COVID and what kind of changes we're going to see in the future. And so like Stephanie said, I have a bunch of guests today, and I'm going to let them introduce themselves. So Sam, do you want to start?
Sure. Good afternoon, everyone. My name is Sam Hoseokal. I'm the Vice President of Patient Experience for Children's Healthcare of Atlanta. I've had the opportunity to work with our telemedicine team very closely as we have, a still developing telemedicine journey in progress. COVID was an incredible catalyst for change and acceleration in healthcare, and we learned a lot along the way. So I'm excited to share our learnings with you that I think you may be able to apply, whether you're a researcher, an entrepreneur, or just interested in healthcare in general. So thanks for having me.
All right, Mary Beth.
Hello, I'm Mary Beth Gandy Coleman. I'm a principal research scientist at Georgia Tech, and I work within the Institute for People and Technology, which is a interdisciplinary research institute. So we bring together researchers and students from all around campus. And within that group, I'm a director of a center of research faculty. And so our mandate is specifically to help translate the fundamental research from the institute into the outside world. So we do a lot more engineering and applied work and kind of long-term deployment and support than you might expect from the university. And in terms of my own personal research, I work in augmented and virtual reality and wearable and pervasive computing, often applied to health and wellness and medicine. Thank you.
Thanks. Hong, how about you?
All right. Hello, everyone. I'm Dr. Hong Yeo. Currently, I'm an assistant professor of mechanical engineering and biomedical engineering here at Georgia Tech. And also, I'm the director of the Georgia Tech iCAN Center for Human-Centric Interfaces and Engineering. In terms of my personal research, as you may see from the shared slide on the screen, my research group is studying a few different aspects of materials mechanics and electronics to develop various types of wearable and implantable nanoelectronic systems. Happy to be here. Thank you.
Thank you. Rob, how about you?
Hi, I'm Rob Menino. I'm an instructor over at Emory and junior faculty in Dr. Wilbur Lamb's lab over in the Department of Pediatrics. And my research is specifically involved with smartphone-based diagnostics for various blood disorders.
Thank you. So I'm so excited to have everyone here today. What we're going to do is hear a little bit from the hospital perspective about how COVID has affected telehealth and what it kind of looks like going forward, plus our three guests on what wearables look like in telehealth as it moves forward. And you're also going to hear from some kids of the International Children's Advisory Network, so the group, the nonprofit that I'm a president of, and you're going to hear directly from kids about their telehealth experiences during COVID and what they liked and what they didn't like. And so actually, I think what we're going to do is we're just going to start with that video so you can kind of get a perspective of what it's been like for kids specifically using telehealth during COVID. So Christy, I think you can play the video for us. what we all want to know is, how has COVID affected you? Andrea, how has it changed your day-to-day or maybe your care?
It really has impacted me with school and with my care. Because of the pancreatitis, I was actually supposed to travel for a new treatment to find a way to like help improve my medical condition. But because of COVID, I wasn't able to travel to Cincinnati, Ohio. And we had our appointment canceled, and we had to be quarantined, and it was such drastic change from going to a regular life and then just being stuck at home.
Okay, and so with that, how did it change your health? I mean, was it okay that you have to wait to go to that treatment, or is it kind of a problem that you can't go?
It was sort of a middle ground. They were sort of worried because I had some ultrasounds before, and they saw something in my pancreas that they thought might be problematic, but they weren't so sure. So it was a middle ground because we're still not sure what's going on. We are hoping that it's nothing that serious. So.
Yeah, and so from that, though, I can see that might be kind of stressful or make you worried. It has affected you kind of mentally, not being able to get the care, not really knowing what's going on. Maddie, how about you? How has COVID affected you?
So, as I said earlier, that I had a double lung transplant, and I was sent to Pennsylvania because the place that was going to do it here, I became too high risk and delisted me. So I was there because they wanted me to do a full year of care. But when COVID hit, they thought I would be safer to go back to Chicago. They thought I'd be safer there. And so all of my appointments have been virtual, except for one when they had to get a bunch of testing done. So then I flew out there. But most of the testing has been, or most of the appointments have been virtual. And then also because of the double lung transplant, because I became so sick, I was in the bed for weeks and became I atrophied a lot and lost tons of motion in my muscles, and had to gain that all back through physical therapy. But because of COVID, that all came to a screeching halt. So it's prevented me from progressing and being at a better place than I am now. But it's starting to pick up again. So yeah.
So with your virtual visits, how is that different than really going in person, or was it really just the physical therapy that was halted? Did you feel like the virtual visits were just fine for what you needed?
The virtual visits for my health regarding my double lung transplant were fine. We still were able to do everything that needed to happen through the virtual visit. It was just the physical therapy that I felt came to a screeching halt and was very difficult to do.
Yeah, so I would imagine that physical therapy is hard to do at home by yourself or with your parents, because did you have any equipment that maybe you couldn't use, or your mom didn't know how to help you? Why did physical therapy have to come to a halt?
Well, because of the amount of time I had spent in the bed for the transplant day, I developed a drop foot, which is where the foot, like the name suggests, it drops. And there's like no motion in it. And so that was like for physical therapy, getting that back and getting my walking gait back to normal and going up and down the stairs. Like some of that I could do on my own, but like a lot of the exercises, it just needed like a physical therapy, like the therapist help. And like we have a treadmill at home that was given to us by a friend back before the transplant happened, but it's hard to use it, especially if you have a drop foot.
What is it like to try to do rehab using telehealth because of COVID? Can you tell us anything specific?
It's been really, yeah, totally. So it's been really complicated. I mean, internet isn't that reliable, and it's been really challenging to find the days to kind of coordinate with my therapist while coordinating with the school at the same time. So it's been a really transitional period at finding the consistent days for us to work together.
Okay. But then the moves and things, do you have to have someone at home help you, or the therapist might have helped you before, or is it really just you doing all the moves yourself?
Yes, my mom has to help me a lot, which is pretty difficult since she has 2 little boys running around. And so it's been really difficult to find the right days and times for us to commit to just doing therapies and stuff.
Nathan, how about you?
Yeah, I've had one telemedicine conference with my counselor at Lurie Children's Hospital, but and it went well. Yeah, basically we just talked about just kind of like stuff we'll do in the future. It's kind of like a once a month thing, but just to check in on and kind of like learn how it might be for a couple months and how we're going to do things. But overall, it was a good experience because obviously we really haven't had to do that, or I haven't had to do that. Virtually, it's always been in person. So it was a good experience, and I think just as time goes on, the technology and the people will start developing the technology better, and we'll be able to see an improvement in that sort of area, technology-wise.
So that was a little preview of what our kids at iCAN do. We consider them the experts of their conditions that they live with, and we encourage them to share their stories so that people can better understand what it's like to be a kid living with a certain condition, and in this case, living through COVID and having to deal with that in addition to their healthcare issues. So now that we've heard from the kids and kind of the patient perspective that, some of it went well, some of it was harder to do or couldn't be done, we're going to hear from Sam about Children's Healthcare of Atlanta and how they, what their journey was for telemedicine, and also what kind of lessons they've learned and what kind of things they want to take forward and what kind of things they know didn't work so well. So Sam, I'm going to let you talk a little bit.
Great. Thank you, Leanne. And thanks for speaking to the key stakeholder in all of this, the patients and the kids. It really reinforces the human impact that these new experiences can have. And it's not always a home run. And I'll share some of those challenges and experiences from our end as well. I'd like to quickly give you an intro into Children's Healthcare of Atlanta. We're a large pediatric health system. We have 673 licensed beds across 3 hospitals, 19 neighborhood locations. We have more than 2,000 pediatric physicians that work across 60 plus specialties and programs. We're opening a 446-bed new hospital in 2024 that will really be transformative, we think. So really exciting time. In 2019, which was a non-COVID year, we saw more than 1.2 million patient visits. About 27,000 of those were inpatient. Our emergency departments, we have 3 of them collectively in 2019, averaged about 673 daily patient encounters. So very high volume, the highest volume pediatric EDs in the country. We're ranked highly in U.S. News and World Report. We're now #1 in pediatrics nationally in NIH research funding and partnership with the Emory Department of Pediatrics. and great partnerships with Morehouse School of Medicine and Georgia Tech. So our mission is to make kids better today and healthier tomorrow. And my shameless plug is that it's a great place to work too. So check out Children's if you're interested in innovating in healthcare. So on this first slide, I really want to share some big questions before I get into what we learned. And so if you go forward one slide for me, these things kind of keep us up at night. We don't have answers to these, but they're very, very important. So first and foremost, how can telemedicine actually enhance and improve access to care? We know it can be more convenient. But if you're simply replacing an in-clinic slot or appointment into a virtual, we're not really adding care. We're not adding capacity. So that's something we consider. And so if that telemedicine technology experience slows that provider down and hinders access, that's a big problem for us. Next is, will we get paid? In Georgia, pre-COVID, we could not be reimbursed for any telemedicine into the home. Currently, remote patient monitoring in Georgia, we will not be reimbursed for that. So while the cat's out of the bag for telemedicine and we think it's here to stay, there's still a lot of questions about reimbursement, and that's really, really important. The next one is a big one, and I want to stress. We are a subspecialty healthcare system. We do not have primary care of our own. We rely on community pediatricians for that. If you think about telemed into an urgent care model, a primary care model, it's really easy to do. When you're talking about cardiac and neurology and endocrinology and orthopedics and where you need physical therapy and all those things we just heard about, telemed at scale and subspecialty is a challenge. Many of our patients need to see multi-specialists. They need lab work. They need x-rays, MRIs. And so we have not cracked the nut on when telemedicine works in subspecialty and when it does not yet. Last but not least, you need to create a great, delightful experience for all of your stakeholders, and you can't sacrifice that clinical quality. So those are big considerations for us, and just want you to keep that in mind. Those are things that are top of mind for us. So on the next slide, I mentioned we weren't getting reimbursed for telemedicine. We didn't have a capability. COVID hits, the community shuts down, business shuts down, and our kids still need to be seen. We decided to stand up a fully Epic integrated telemedicine capability through a third-party vendor. Epic is our electronic medical record. We did it in about 5 to 6 weeks. Our telemedicine team did a fantastic job. Our security team, our IT teams, our training teams. This would have normally taken us about 5 to 6 months. So you see this dramatic spike in telemedicine visits where some practices went from 0% of patients being seen through telemedicine to some being seen 40, 50%. Once we get this capability stood up and we're kind of getting our feet under us, the governor here in Georgia announced that Georgia was reopening. It was one of the first states to reopen, and we had to shift so much focus into readying our physical spaces and environments, overhauling our processes, making sure arrival was touch-free. So a big strategic focus went back to in-clinic. By about July, we noticed that we had capacity issues and we were not maximizing our in-clinic. So strategically, we said, let's fill our in-clinic appointments. We're doing it safely. Families are telling us they want to come back and that they feel great and safe when they do. So that's kind of this spike and natural decline. We're still using telemedicine. It's just not the top strategic priority for us right now. As you can imagine, we cut a lot of corners. When you do something that would normally take 5 or 6 months and you do it in 5 or 6 weeks, you don't have time to design and pilot and test and have all of your stakeholders at the table participating. You're making some decisions blind, and you have to do that. There's some implications of that. If you go to the next slide, one thing we had to do was educate our patients and families on they needed a MyChart account, which is our patient portal, in order to register and fill out their paperwork. They needed tip sheets on how to log in and test their systems. Well, here you see our call volumes into our call center. Families needed help. Our volume spiked 2 times, 3 times, and the length of those calls spiked 2 times, 3 times. Absolutely crushed us. But it's a great reminder that technology is often the easy part. It's the processes and the people dynamics and the support infrastructure you need around them to make them successful. We didn't have the luxury of time for that, but it certainly presented some challenges. So before I wrap up, and I'll highlight some more challenges in a little bit, I want to share how did our families feel about telemedicine encounters? So if you go to the next slide, we do patient satisfaction surveying on 100% of our families and see response rates from 12 to 25%. So on the next slide, you're going to see some qualitative comments about when telemedicine worked really well. I love this, was amazing, saved me a 4-hour drive, same great service. Hey, the technology was easy, and we heard time and time again, our care providers, our physicians were so engaged, and families couldn't believe how intimate and connected they felt when it really worked. On the next slide, here's some comments about when it didn't work. This first family acknowledges, wow, I was kind of able to skip the line, and I was able to be seen so much faster, which was great, but it wasn't a very effective appointment because there wasn't a physical exam. And this one on the right is very powerful for us about the technology. You heard it from the kids that just spoke about glitches and technical issues. And this quote is really powerful for us. Glitches like that are frustrating in any meeting, but when it's as important as my child's health, I need to know I didn't miss a word. And so while we at Children's can control technology on our end, those patient family devices and Wi-Fi and cell connections have to be up to speed. We didn't have time to build bots or staff people that could hold their hand and test all of that in advances. So we certainly had some challenge. On the next slide, you can see some of our qualitative patient satisfaction data. And on the top, you see some survey questions that are asked on both the in-clinic and telemedicine surveys. These percentages represent top box responses. So did the care provider listen well? Even a little better on telemedicine than in clinic. They would recommend the provider. They trusted the provider is a little bit lower, but it's still very high nationally where we want to be. And they'd recommend Children's in both environments. On the bottom, you see how those scores dip quite a bit, though, when it talks about method of connecting, the quality of the video visit, and that's consistent throughout the country. There's some real opportunities there to iron out those technology issues. And so certainly we learned a lot. It's been a great journey for us. We now have this really robust capability and the opportunity to refine it and really improve it going forward. So I appreciate the time, and I can't wait to hear from the other panelists and hear what the future looks like. We're excited about that.
Thanks, Sam. That's really interesting. It's good to know what the hospitals are starting to see and think and how we might be able to improve things moving forward. But thinking about moving forward, what will telemedicine look like in the future? And so that's why we have Rob and Mary Beth and Hong with us today, because we think a lot of the future of telehealth is going to be in maybe an app or a wearable device of some sort, and taking data constantly. And so I just want to give them a chance to talk a little bit about their research and what they do with wearables and kind of their thoughts on where wearables are going to go as we move forward with telehealth. So, Rob, we'll start with you.
Yeah, so Sam brought up an interesting point in that talk where you can't actually do these telemedicine appointments, and that's a major limiting factor. So my research addresses that, really. Pretty much everyone has access to a smartphone at this point, at least in this country, and there's actually a pretty significant amount of computing power in those devices, and the cameras associated with them are getting better and better. So you can even see, usually on these like Zoom calls that everyone's on nowadays, people with the poor video quality, those are the people on laptops. People with their phones, even the front-facing camera, usually is much better than any of the laptop connections. So my research specifically was the first thing I did while I was in grad school in Wilbur's lab was to develop a smartphone app that can measure hemoglobin levels by just taking a picture of patients' fingernails. So this was really stemmed from very old school medicine, where a physical exam of a patient's paleness could tell you a lot about potential issues that they might be having. So typically you hear, if you're looking pale, you could potentially be anemic. So I found that by actually quantifying the amount of paleness from pictures that you could take on any smartphone, you could come up with a specific hemoglobin level for that patient and know whether or not they're anemic. And I think that these are the types of things that telemedicine and smartphones can address in the very near future. Another good example, pretty much anything that you can diagnose via like just a visual exam, I think is a target for these new technologies. Another good example would be skin cancer. Basically tracking and measuring lesions where you can, augment that patient-physician experience without actually having to see people. And I think that the pandemic really kickstarted this whole conversation. I guess an interesting thing for me and Wilbur was that we had started a company to commercialize this technology, and we hadn't had any, investor backing besides the government grants that we were working on. And then once everyone switched to digital, that's when we start getting a lot of interest and getting funding to continue the work. So I think that the area is only going to continue to grow, especially as people try and stay home more.
Thank you. That's great to hear that you've gotten some more interest in what you are building. I've always found that project to be fascinating because the other way that people used to have to tell or still tell if they're anemic is taking finger pricks and getting blood, right? So this is a non-invasive way to do that, a non-painful way to do that. So thank you for that. Mary Beth, maybe you can tell us a little bit about what you work on.
Yes, thank you, Leanne. So I really enjoyed hearing from our, as Sam said, our most important stakeholders there. And I also really wanted to emphasize that one statement he made about you've got to consider all the stakeholders and creating an experience that's going to, a very positive experience. It's going to delight everyone involved, ideally, right? And that's hard to do. So there's these tough engineering problems, like how do I make this new sensor that will collect this data in a way that's never happened before. Now, where I work at is this human-computer interaction level. So trying to understand how can we create a relationship between the people and the technology and, and an interface between them that actually works. Because many times these kinds of technologies are a failure because when it comes down to it, it's not accepted by all of the stakeholders. And I keep saying all the stakeholders because when we're talking about wearables, if I'm wearing some technology on my body, yes, you have to consider my experience with it, but you have to consider everyone else's too, especially with children. Their parents are having to help them with this technology. Their teachers may be helping them. Their peers, at school or elsewhere are having an experience with it. Google Glass and some of the reaction to that is a cautionary tale. Here is an amazing piece of engineering, a wearable device to deliver, information services over a display. And it was viewed very negatively by a lot of people, not that were wearing it, but who were seeing people wearing it and were just concerned about privacy, right? And so the work that I do is about, one, trying to understand what are these really amazing things that we can do with immersive technology and wearable devices, right? We can collect data. We can connect people to communicate in ways they never have before, and we can deliver these innovative health interventions. But what's needed is user-centered design. And so I have another cautionary tale. I was an external advisor for a federal program looking at pediatric asthma and creating wearable devices to study pediatric asthma and also to deliver new kinds of interventions, right? So I'm in these meetings and there are amazing engineers creating sensors that have never existed before, solving really hard problems. And they're showing me all of these things that 8-year-olds are going to wear. And, I was like, well, so you're doing participatory design with your stakeholders? They said, oh no, in year 4, we'll do some usability testing. But right now we're building this. And I said, so do you think that the 8-year-old is going to wear that giant metal box with a fan in it? And the answer was, oh yes, because their parents are going to tell them that they have to wear it, right? Anyone who has an 8-year-old knows that that's not the case, right? And so I was very diplomatically trying to teach these folks that were world leaders in electrical engineering and mechanical engineering, but no kid is going to wear that to school, or they may, and it may have these really negative effects on them. And so part of this user-centered design process that's, I think, specific for wearables is understanding these contexts of use, which isn't just the physical environment, but the social one as well. And how is someone going to feel being seen with this thing, right? And do they want to be seen or not? And so I'll conclude by saying the work that we're doing in my group, a lot of it is on creating these new transdisciplinary design processes, because no one expects the electrical engineer to have all the answers for this, right? What we need is to have psychologists, public policy, human factors, design, teams working together to solve these problems, but there aren't tools that help you do that very well. So one of the things that we're building right now as part of the wireless RERC at Georgia Tech is a wearable product design tool. So it's a web-based tool that people designing wearable devices can go to, and it really captures this knowledge base of everything we know about how to build wearables based on body placement, sensing capabilities, the physical and cognitive capabilities of the wearer. And so you basically select all of these requirements for your device, and then it spits out both like a visual map of the various choices that you may want to make, and as well as a really detailed report explaining what all of these design recommendations are.
Yeah, so that's fantastic. I totally agree with you on including all the stakeholders. And I think one of the stakeholders is also the clinician who's going to be looking at the data that the wearable captures, right? And what can they do with it? Excuse me, and how can they make it actionable?
Yes.
So I think that's always really interesting too. There's a whole lot of stakeholders on both sides of the equation. Mm-hmm. And then the other thing I want to emphasize that you said is work with stakeholders up front. In iCAN, what we do is we suggest talking to our kids from the very beginning, even about what a consent or an assent looks like, or a protocol might look like. Talk to them about usability, but up front, like what kind of things can they think of off the top of their heads in the beginning to help guide you as you build your first prototype. And then you can continue to do studies along the way. So 100%, I absolutely agree with everything you said. So thanks for sharing that. Hong, why don't you tell us a little bit about what your research is?
Hi, thank you. It was great to hear what others think and what's going on right now. And especially, Mary Beth made a really good point about, issues of existing devices and from engineers like me. So as a mechanical, biomedical, and electrical engineer, I'm developing various types of wearable systems, as I briefly shared from the previous slide. And we are really trying to tackle those issues of existing sensors and electronics. And as Sam showed from his talk regarding telemedicine, when I heard about that, I immediately thought about, well, we definitely need better sensors and better electronics that can be easily usable at home instead of going to hospital. There are available devices out there. Obviously, some of clinicians use those devices. However, as Mary Beth mentioned, the existing devices are still very bulky, heavy, and has limited functions. So my research group is using different materials. We are not using any thick metals or rigid plastics, anything like that. Instead, we use ultra-thin nanomaterials, polymers, soft materials, stuff like that, to build nanomembrane-based wearable sensors and electronics. So in terms of form factor, it's completely different. The overall size of each sensor is very similar to a single Band-Aid. So like a Band-Aid, you can just put that device onto your skin to measure something that you want. For example, right now we have over 20 funded projects from NIH, NSF, DOD, and so on. For those projects, we are working with more than 6 hospitals in the United States. So we get inputs from clinicians based on target population regarding usability and others. So based on that, we design those miniaturized, pretty much imperceptible wearable devices that can measure pretty much everything that currently hospital systems can measure, like heart signals, brain signals, blood oxygen saturation, eye motions, body motions, muscle activities, and so on. So this single device platform that we are developing is completely wireless. You can get the data wirelessly through smartphone, tablet, or RFID, many different ways. At the same time, this device has multiple sensors in it. So without having like 10 devices to your body, we can use single device to measure multiple things at the same time. So that's something that currently my group is working.
Yeah, so I love what you're doing. And just to make you expand a little bit, I know you are working with Children's Healthcare of Atlanta on some projects about remote monitoring of patients and infants. If you maybe just want to talk a teeny bit about what you're doing with them, that project a little bit, I think that would be really interesting.
Yeah, sure. Yeah, currently I'm working with clinicians at NICU, Neonatal Intensive Care Unit at CHUA. I don't know whether you ever visited NICU. Whenever they have patients have issues, they are hooked up with multiple sensors, multiple wires with tabletop systems. So they are really basically immobilized onto that bed because of those health monitoring systems. And now we are making this, the one that I mentioned, like Band-Aid type single device, wearable device. They can be mounted on the chest area, that measures multiple things that I mentioned already. So those babies or infants can really move with these sensors and electronics without any issues of losing data. And at the same time, their parents can hold their babies and kids without worrying about sensor disconnection and alarming and so on. So that's something that we are working on right now, which was funded by IMRE Foundation grant, and that's something we are continuously working on at the same time.
Great, thank you. I know that part of the idea behind that one is how you can monitor kids in the future, and can we make it easier, like you said, and something that's more portable, less intrusive into the life of the patient.
Sure.
So to kind of circle back a little bit, Sam, I wondered if you could give us an idea of what Children's Healthcare of Atlanta might be thinking about wearables in the future and how they might play into healthcare from your perspective.
Yeah, I think at a system level, we don't have a strategy around this. I think there's going to be opportunistic, targeted things like Hong is working on that can really provide value. But I think at a big picture, we recognize, number one, what an incredible time it is. The kind of convergence of 5G, which will help these families and enable this to happen remotely. The low-cost precision sensors being designed better. Rob mentioned the incredible computing power we all have. And I think most importantly is the interoperability regulations that have come through that is breaking down kind of the walled gardens and forcing systems and health data to share and make these companies not protect it and make things more accessible. So that is going to open up a ton of possibilities there. I think a reminder is, what did we learn from our telemedicine ramp up? The easiest part may be the technology. It's who's going to process all of this data, as you mentioned, is extra nurses, extra doctors you need so that they can apply it at that personalized care level. Will AI allow us to do that in big data analysis? So there's still a ton of questions, but what an incredible time to do this. I think about opportunities that are probably obvious. We talked about asthma and diabetes, these chronic care dynamics, and what are those subset of patients and families that have challenges in adhering to their care plan? Maybe there's distance, maybe there's socioeconomic. How do we make it easy for them to be better and maintain better? But what will it take to educate them and train them and stay on top of them? So again, it's the support infrastructure beyond the technology that is really going to make or break some of these things. I think the innovations are going to be there. It's the infrastructure and people and process sort of things. I'll just remind you in healthcare, and from inside here, I've been in healthcare now for just 4 years. There's a constant evaluation of investment trade-offs. There's so many needs and so many opportunities. So if we have to make a case for an extra researcher, an extra social worker, an extra nurse or clinician that's going to analyze all this data, and it might be a narrow patient population, what could we do with those same resources for a very large patient population? Where are we going to get the more juice for the squeeze, so to speak? So those are considerations that we have. And I think you're all doing a great job, what you mentioned. You have to have these physician champions. You have to have the end users, the patients at the table with you, co-designing along the way. So really exciting time.
Yeah, I completely agree. So one last question for some of our wearable panelists. I was wondering if you could tell us a little bit about, if there's anything in your perspective that changed for wearables because of COVID. Is there anything new, having lived through this last year of being locked away at home? Is there anything new you might have learned or thought about for wearables? And Rob, I'll let you go first.
Yeah, so I guess over the last year, the main thing I've learned is that these like wearables and devices are only getting better, right? So not only like when you design tools that interface with them, you have to be prepared for the improvements in technology and make sure that you're constantly thinking about updating and try to be thinking like multiple steps ahead for how updates in the technologies can be used to improve the patient experiences of the devices that you're working on.
Great. Mary Beth, what about you?
The one thing that stands out in my mind is that COVID forced us, so I'm going to look at it from this, what do we do with immersive technologies like AR and VR, right? And what we learned this year, we had to repurpose these tools like Zoom and Blue Jeans for all these uses that we never did before, whether it's having Christmas morning over Zoom, or my daughter taking voice lessons over Zoom. As a researcher trying to run studies with participants over Zoom instead of being in the lab, right? So it was this really interesting, experiment in, can we take this? Ultimately, these tools were designed for adults to have to have planned meetings with each other with talking heads. And we all realized very quickly how poor these tools are for these other things that we're trying to do, including, of course, telemedicine. In my own family, we've had to have telemedicine visits that we never did before. And so as someone who works with these immersive technologies, it has me thinking even more about how can we create new sorts of displays and new sorts of interfaces that allow us to free ourselves from this glass rectangle that we're all peering into, right? A lot of the trouble I've had trying to run studies, and I'm running studies with older adults and with children related to health, is that I can't see their space. They can't show me things. They can't move around freely. We can't share artifacts like we would in real life, where I can show you something and point to it. And I don't have answers for you, but I'll say that it opened up a box of all kinds of really interesting research directions to explore, over the next many years.
I have to say that I completely agree with you, that I feel like we've all been a part of an experiment over the last year. Somebody's watching us and taking notes on how we do everything and can we adjust. So I feel that too. Hong, what about you? Do you have any thoughts on how COVID has maybe changed your perspective of wearables at all?
Yeah. Again, as an engineer, I do see that we will see more wearables and better wearables from now as time goes on. And that's what I already saw from this COVID pandemic situation where I did, proposal reviews and other things. And I do see that many people are spending more time to make better sensor system that can be, usable in a way that is portable, wireless, and so on. And just sharing one example that I personally experienced was that I was sitting down with somebody, a clinician at Emory University, and then he complained about, the mask respirator he's using, which was not really comfortable, and he's worrying about COVID infection and others, but there's no way to see whether the fitting was perfect and things like that. So that got me an idea that, maybe I can develop a smart face mask respirator that has embedded sensors so that it can tell whether the fit is great, whether the temperature issues over there, and things like that. So we got funding from CDC here to develop that smart respirator. So I do see that because of this pandemic, COVID issues, some people got new ideas to really help those medical folks who are really facing this challenge.
Yeah, you're exactly right. And I love your creativity on that, thinking about how you could make it better. I mean, I know that the respirator masks weren't really meant to be worn all day long every day. And so I do think there was a lot of opportunities there to make it better and plan from that now when we design these things in the future. Stephanie, do you have any questions that you want to ask our panelists?
Hi. Okay, great. Thank you, panel, for sharing your experiences, wisdom, and research. And thank you to those audience members who have submitted their questions. The first question we've received is, how have other countries applied telehealth during COVID, and who are the global telehealth leaders? Have there been any collaborations?
So that's actually a really good question, I think. I can just say that I know that we have worked internationally with my group and with our kids that are international as well. It was really interesting to learn early on from Italy how things were going there, so we could kind of prep here and understand some ways to do things better. And that was really just because of their circumstance of having it spread so quickly there. But I don't know if anybody else has worked with other countries or seen some things that are of interest.
One thing that I can share is that working with another biomedical engineer at Georgia Tech, we had a chance to get funding from Bill and Melinda Gates, where we can develop those wearable devices for patients in Ethiopia, mostly for kids and infants, because they have really limited resources and they can highly unlikely visit those hospitals, and they have a lot of issues with their hearts and other things, but they don't have any tools to measure their medical conditions and so on. Even at a hospital, they only have like 10 cardiac monitors for like more than 200 or 300 patients. So currently we are working on that, on something that we could just deliver our device, like a Band-Aid thing, so that they can put those devices at home and monitor something. And this device will have AI-based machine learning thing. They can immediately recognize those basic symptoms, and then it can be alerted to clinicians to follow up. So that's an ongoing collaboration. I do believe that this opportunity can be really useful for developing countries where they have limited resources.
Yeah, and I'll add to that that it's been really great actually to see countries work together and across borders and share things they've learned and make technologies that you can remake to use in a setting like Ethiopia. But Rob, I'll let you go.
Yeah, I was just going to echo those comments that I've seen a huge interest for these types of technologies in low resource settings. I guess with smartphones especially, even though, so in a lot of low resource settings, the whole concept of landlines never really took hold. And so smartphones kind of just leapfrog that whole technology. And in some places, even though medical infrastructure may be lacking, with a mobile phone infrastructure is, on par with how it is here. And so I've had some collaborations in India and Peru to kind of go out and take my app into remote rural areas to test the app and do some anemia screening in those types of places. And I think that with the pandemic, where healthcare infrastructure has been even more restricted and crunched in those places, wearables and smartphone-based technologies are even more important.
Yes, I couldn't agree more.
Okay, great. Thank you. The next question is, can the panel discuss more about the issues related to the safety or confidentiality of personal health information that is shared through telemedicine, or technologies that document medical symptoms, diagnosis, etc.? And what happens when this data gets breached?
Hey, this is Sam. So I'll share a little bit of what keeps us up at night. And certainly if you think about pediatrics, very easy for an adult to walk into a healthcare facility, show them their ID, and you know who you are. In pediatrics, the level of protection and challenges are much more difficult. You may have a stepfather. The family is on that stepfather's insurance plan, so the stepdad is the guarantor, but they're not legal guardians. So they're now who's applying for this MyChart account to get that health data, to look at the health record. And now we're publishing our clinical notes, thanks to the 21st Century Cures Act, which I encourage you to review. It's just been actioned. We're now, and all of our peers are sharing clinical notes more than ever. There's a dynamic to the 21st Century Cures Act, which takes it further, that if you go to your gym and they ask you, hey, would you like to share some of your health information with us, the gym, you might click that box, yes. That health system may get a request to provide your medical record to the gym. And so this is all new territory in the 21st Century Cures Act. And as a health system, we're like, wait, as these requests start coming in, which ones are valid? How much information should we share? What are the penalties if we don't share? So it's still a bit undefined. We're learning as we go. But I mentioned early interoperability and these federal dynamics that are driving greater sharing. It's going to be great for consumers, but it's going to definitely increase the risk that this data is going to fall into questionable hands.
Yeah, I will say that on any project I've worked on, that data security is, right in the front of everything that's being done. That's one of the things that researchers really try to take into account when they're designing something. That's one of the requirements every single time.
And of course, another important part of this is that the interface and making sure that the user, yes, there's cybersecurity that has to be figured out. There's policy decisions that have to be made, but also we have to make sure that the owner of that data, the person, understands what's being collected and where it's going. And, we're often presented with these really just, long EULAs that we're saying yes to, right? Like Sam said, we may not even really understand what we're saying yes to, or we may not understand what's being collected by some technology. People get very disturbed by cameras being on things, for example, because we're imagining, oh, this is being recorded and it's being shared. And then alternately, sometimes there's devices that are collecting really sensitive information that we may not think about, like the robotic vacuum that's moving through your home is creating a real-time 3D map of your environment and possibly streaming that somewhere, right? So in some cases, it may not be that the device is collecting video, but as part of its sensing, it is collecting this really, again, sensitive information. So as someone designing that human-computer interface, I need to think about how to make sure people really are informed and that the systems are transparent about what they're doing.
Yeah, I just want to add on to one thing that you mentioned about owning the data, the owner of the data being the person. And actually, that's not necessarily true, depending on what device you have. The company may own your data and may be able to share it. So I think there are a lot of things out there that haven't necessarily been resolved or that people just aren't as aware of as they should be. And it's going to be interesting to see all of this move forward, I think.
Great. I think we've got time for one more question. So I just want to ask you guys, it was said earlier that the patient is the expert on their condition. So I want to know how you guys think telemedicine empowers these people, especially children, throughout their care.
I'll start with that. I think that a lot of times when you are a kid or even an adult who suddenly gets sick or has something happen and change in their health and well-being, you might feel out of control or lost. And I think that anything you can do to give that patient the ability to feel like they're in control of something, you're helping them and you're empowering them. And so to some degree, I think for a patient being able to collect this data about themselves and start understanding what some of it looks like, I think that helps them in that control environment where they can control something. And so I think it empowers from that standpoint, but I'm sure others have other comments on that.
Oh yeah, I completely agree. I can go from personal experience. So the real backstory about the work that I'm doing starts from when I was a patient with you guys at Children's. I have a blood disorder called thalassemia, so I was treated at the Aflac Blood and Cancer Disorders Center over at Scottish Rite like my whole childhood, and I completely think that I was always curious about what I had and always asking questions, and I think that providing more access to people, to patients and kids, gives them another outlet to learn more about what they have and take charge and manage their disorders. And sometimes it can, for like a lifelong career obsession with the type of things that they're dealing with.
Great. We did get one more question, so I think I'll just try to squeeze it in with our last couple of minutes. Does a provider's ability to screen for child abuse suffer because of telemedicine?
Absolutely. I mean, I think there are definitely clinical indicators and protocols that can definitely see and pick up live that you wouldn't be able to pick up through telemed. So I think there are definitely some limitations in its applicability in instances like that.
Great. Okay, thank you so much. As we're getting close to 1 o'clock, it looks like we're just about out of time. Thank you all so much for joining us today, and thank you to our panel. Please continue to monitor our website for upcoming Smarter Together webinars. Thank you so much.
Thank you.